So now we're going to invite the speakers up because we have questions for pretty much everyone. Okay, I'll give them a chance to come up. While they're coming up, I just wanted to say thank you to everybody who provided questions for the question and answer sessions. Some of you provided similar questions, so you'll notice that we've rewritten some of them to try and incorporate them into maybe one question or a couple of questions. Some of your own questions may personally sound exactly the same, so some have made it in unchanged. While we cannot possibly get through all of the questions today in the question and answer session, there may also be opportunities, of course, during the community resources panel for you to come to the mic and ask your question also at that time as well. Okay. The first question looks like it is for Nadine Burke Harris, but it may be answered by anybody. Are the different components of the ACE score considered equal in the manner that they confer risk, or are some more equal than others? We know that any 4 or more translate to an array of risks, but do we know if any specific combinations are associated with different levels of risk?
Okay, that mic is really working. So Felidi and Anda did do this analysis to look at whether or not the different ACEs are weighted differently in terms of their risk of long-term health outcomes. And what they found in their analysis was that they were more or less co-equal. So each of the 10 ACEs that they looked at when they did the statistical analysis more or less conveyed the same risk for long-term disease problems.
Thank you. Nadine Burke Harris and Denise Dowd and others. Several members of the audience have posed questions surrounding the intersection of ACE screening and Child Protective Services risk. Is this like opening Pandora's box and an increase in CPS referrals? Do you see that with ACE screening? Is there then a good community resource for these high-risk families? How do you address that concern and the adversarial relationship that you can see with these families and Child Protective Services?
Do you want to start, Denise? Or?
I know it's several questions. It's more related to, you open up that sort of concern for, do you involve Child Protective Services when you start doing ACE screening, and how do you sort of address that in your practice?
It's not working. Okay, well, while Denise is working on hers, I will say for mine. So one of the, interestingly, even before we moved to a de-identified screen, we in our institution did not have to deal with a lot of CPS reporting. My experience, no, let me back that up, because of the ACE screen. So my experience was that it was rare that we did an ACE screen, and as a result of that screen, we ended up having to make a report. What was more common was that we screened a child, we'd been doing the screening for years and years and years, and a family who had experience of us coming in and at every well child visit, talking about these things and saying, if there's ever an issue, please let us know. We have resources to be able to help. And this is no joke. One family came in for a PPD reading, which is a like a 0-minute visit. One family came in for a hemoglobin. One family, they all come in for this, random stuff, and they say, oh, by the way, Dad punched him in the face yesterday. Is that something that you can do something about? Oh, by the way, I think that, I had to work this weekend, and so I dropped the kids off at Grandpa's, but Grandpa is a molester, right? So those are real. And so what I found was there actually was likely an increase reporting, but it didn't come at the time of the screen. It came whenever that family experienced readiness to disclose what was going on. But despite that, I think that we did move to the de-identified screen in part to respond to providers' fears about screening. And one of the things, not only providers' fears about disclosing, but also caregivers and patients' fears about how is this information being used. And the way that we do it in our practice is so that they write down the number, and that number may be a 7, but it's de-identified, and so we don't know which ones. Then what happens in our practice is that the family is referred to what we call a wellness coordinator. It could be a social worker, it could be a case manager, who then goes through and does an identified screen. And they have, an hour and a half, whatever the time is. So while I'm off dealing with my next patient, doing my next physical, or seeing the next, ear infection or whatever it is, there is someone who has the time and space to be able to hold whatever disclosure arises and is able to take the time to walk through that.
I don't have too much to add to that. Our screening is at this time is not done in our medical clinic. It's done sort of what I call on the other side, or the Operation Breakthrough Head Start side, and it's de-identified for them as well. And I think everybody knows, because advocates, social workers are built into the system, that they can go to those individuals at any time, and that the environment is a different environment. It's a positive, nurturing environment, and I think we will struggle with screening in the medical clinic. I think we have one of our providers here. She was here at least, and there's Gladysha right there. And it will be interesting to know when a new medical director comes on what that will mean, because there's always concern that, gosh, if we identify something, then we're a mandated reporter and we're going to have to do this, and therefore we're going to lose, we're going to break trust with the families. I will say that one program that we do have, which is Intimate Partner Violence Screening Project in our hospital, we've done it in the ER for several years. This was a huge concern. Huge concern. What are you going to do if she says yes, and how are you going to assure the safety of the parent, and you're going to have to call CPS and so forth. And it really worked out because we put some guidance in there. We said, straight up, we're mandated reporters. If we think your child's, at a direct risk, we're going to have to report. Let me ask you a series of questions. I'm going to examine your kid. If there's physical evidence, we're going to have to do this. If your child's been directly threatened, we're going to have to call CPS. And you have to have a plan for what to do when something goes down, something at risk goes down. And people are very, very accepting of that. It hasn't been an issue.
Okay, so if you have more for them, bring that up to them afterwards. So we'll move on a little bit just for the sake of time, because I have a big stack here. Dr. Gillespie, you talked about enhanced anticipatory guidance in the practice. Do you have any pushback from your partners in terms of the extra time that might take in the examination room?
Not a lot. And even though we have provided these extra anticipatory guidance questions and extra handouts and brochures, I will say that the providers each have their own unique response in terms of what they actually do with the information. So the responses tend to be more organic and tailored to the family. That said, when I surveyed our providers to find out what their time commitments were to this, the average initial conversation was 3 minutes. And so they weren't spending a lot of extra time on that particular issue. And the other thing that I would point out, that if you are following the anticipatory guidance from Bright Futures, most of the priority areas in the early childhood anticipatory guidance sections actually are about family support and functioning. And so it actually it slides into that domain fairly easily. So I've not had a significant amount of pushback, but again, I think people use the parts that they need based on what their conversations with the families have disclosed.
And this could be answered by any of you. What about coverage by the insurance company for diagnosis and treatment? And second part, how would you then also get coverage for the social work component in your office setting? Everybody wants to know this. There's been lots of questions on coverage by the insurance company.
That's awesome, right? Yeah, because we all get paid so much for the extra screening and stuff that we do. So the short answer is no, although Oregon did recently pass legislation that any qualified mental health provider embedded within a medical home can bill Medicaid for their services, which is helping us in our journey towards behavioral health integration. But by and large, and that includes licensed clinical social workers. So we're heading that direction, but we've not seen any extra funding come in.
I think this is a tremendous place where the AAP can provide, can lead with advocacy, and I know that this work is already underway in terms of the AAP advocating for reimbursement for this work. But it's absolutely critical. I mean, at our center, we have to fundraise to be able to raise the dollars for the arms of our organization that do pieces that are not reimbursed. The other challenge in that I want to point out is that right now there's no clinical diagnostic criteria for toxic stress. So there's no ICD-10, right? And it's funny, it's like I guess toxic stress is like porn. I know it when I see it, right? But I unfortunately, even for all of us as we do our presentations, we can't say, here's the clinical diagnostic criteria. And that is some of the research that we're doing at the Center for Youth Wellness to advance diagnosis and treatment. But this is some of the work that needs to come down the pike. And so the one thing I do want to say is that a recognition that this is an emerging field, and we as primary care pediatrics really and truly are on the front lines. And so if there are folks who are at academic medical centers, I do want to encourage folks to think about that as a topic of research in terms of clinical diagnostic criteria for toxic stress.
I think that the issue of reimbursement is above my pay grade, although I do know that there is a wonderful stuff on the AAP website about coding just for a lot of the somatic issues. But the one of the idea of the co-located social worker financing thing that came out of several of the groups in our learning collaborative came up with is the idea of trying to have somebody from another agency place their person in your office and have them still be financially responsible for that person. I see some heads nodding with the idea that can often be a win-win in the sense that given that almost every community mental health organization has a really significant problem with show rate, that having somebody spend some time in your office where their show rate will almost by definition be much higher often can be a situation that's advantageous for them and provide a service for you. So,
Can I just add one thing?
Yeah.
No, I can't.
Yeah, no, you can.
The other resource I would point people to is on the AAP website is it's called the Trauma Guide. You can type in AAP Trauma Guide. And part of that is a coding guide as well, and that's being updated and will be available for ICD-10 very shortly. Right now it's still got ICD-9 codes, so you can kind of transcribe it yourselves, but that is available already on the AAP website.
Okay, so I'm going to combine some questions on ADHD and pass these to Dr. Forkey and Dr. Wissow. Several audience members have questions on ADHD, and in their questions they talk about the significant overlap perhaps between the child in the office who also has a parent with symptoms. How do you separate out the trauma from the gene? Also, what do you do when you have parents and schools who want the quick fix and they want the medication versus the trauma-focused sort of counseling? So how do you change the culture in our community? And so what do you have in terms of answers for our audience on these questions?
I can start. So this is the question that we get a lot. Could the child have both? Absolutely. Do stimulants help everyone? Yes. So usually where I go with that is I sort of see what do we need to get through the day. I think sleep and ADHD medications are where I'm starting in terms of what do we need to get through the day while we deal with the underlying problem. And I talk to families about this being like the cast for your broken bone, that we may need to do some supports while we deal with the underlying issue and get some healing going on there. I think one of the things that I try to do when I hear from a school that they want me to up a medication or change a medication because the ADHD medication's not working, and fortunately for me, I actually do have, that history of present illness is kids are coming into my foster care clinic or child abuse clinic, so I actually know they have had these issues. So I often call back to the school and say, can we differentiate at all whether what we're seeing is inattention or hypervigilance? And we talk about what the difference is. And we try to parse apart some of those symptoms. Certainly, sometimes people have time to listen and hear me, and sometimes they don't. But I would tell you that I think the community is as hungry for this information as we are, and that they see that this is part of the issue as well. So the short answer is, do I still use stimulants? Absolutely. I often say we're going to revisit this and see if we still need it after we've also gotten into some trauma therapy, and revisit how much can be if we can pull this off.
Yeah, I couldn't agree more, and I think that this idea of trying to communicate directly and partner with teachers to the extent that you can do that is really critical, because I remember that my coping in the psychiatric emergency room was always trying to realize that the people I was dealing with in other agencies saw their job as impossible as I did, and that by being mad at them or try, I wasn't going to necessarily get anywhere. So I think trying to sort of help teachers understand what this differential diagnosis could be, valuing their input, valuing their expertise, and understanding what their sense of urgency comes from can sort of go a long way to helping them give you the space to work out what might actually be the difficulty with the child.
Pooling several questions on parent and caregiver ACE scores. How do you address the ACEs in the parents, and how the caregivers should probably also change circumstances in their lives to improve the ACE scores in their children? And then also, are there outcomes data for the two generational models of screening caregivers and children?
I'll jump in and say that one of the most effective interventions that I see is child-parent psychotherapy, which is pioneered by Dr. Alicia Lieberman at UCSF, and we have members of our team who do CPP, and that works with, the therapist works with it's for children 0 to 6, and in that case, the therapist works with the child and the caregiver. It's dyadic therapy in which they explore, in addition to the child's behaviors, the caregiver's history of trauma or adversity, and helping to work through the caregiver's history of adversity and recognize the ways in which the child may be a trigger. For example, if there has been domestic violence at home, then when that child who has witnessed that domestic violence there then goes to hit their caregiver, right? They may be reenacting or re-experiencing something that they have witnessed that was traumatic to them, but for the caregiver, it's also a trigger, right? And so recognize how that cycle works. And so that is a really fantastic intervention that I think is one of the most effective that I have seen. I think that in terms of other ways that we at our center, because we are privately philanthropically funded, we raise a lot of money for our clinical programs. We actually don't require that the patient be the one who is seen. So oftentimes, if there is a mom who has 4 kids and all of them are struggling, and the caregiver is really struggling to be a buffer to her children because of her own history of adversity, what we do is we provide therapy for the mom, right? And sometimes that's in addition to the services that we provide. So we actually do biofeedback for parents of children who have high ACEs, and therapy for parents of children who have high ACEs. And oftentimes, and then the other thing that we do is help to connect the caregiver to, so we will sometimes follow up. I will sometimes get a release of information to talk to mom's primary care provider, and in some case, getting the mom on an antidepressive medication is actually the best thing in the world for my patient's asthma management, right? I mean,
That's a great answer. Oh, Mike, that's a great answer. So now that I have the mic back on, we're coming right towards the end of the 15 minutes that we were talking about for the Q&A, and I have still all these questions here that I'm going to blend in as we're going sort of sliding into the community resources panel. So in the community resources panel, we are going to have several of our speakers spend just about 5 minutes first to give you some thoughts on how they've engaged some of the resources in their community. And then we're going to sort of entertain questions at the microphones, which will be turned on. And I also still have some of your questions here, and I'll try and weave them in depending on the numbers of folks who come to the microphones. But I have one question here that I'm going to pass to you, Nadine, while you're hopefully giving your 5 minutes, because I think that this is something important, which is, while you're talking on your 5 minutes, how have you worked with the business community to develop business models to sustain a comprehensive center for family wellness? Okay, and with that, I will pass it to 3 of you to give us an idea on how you've engaged some of your community resources, and then we'll do some more question and answers during the panel.
Thank you. So I'd be happy to jump in and get started by answering that question in terms of how we have engaged the business community. In the Bay Area, there's something called the Bay Area Council. We also have quite a number of partners, and I mentioned that we're entirely privately philanthropically funded, and for a fair amount of time, that was a huge pain in my behind. I was so frustrated. Why do I have to spend this time fundraising? And my husband said something to me, which is that when you reach out and you really have to explain your thesis and your theory of change to folks enough so that they're willing to be enough of a partner that they will support you financially, you enroll them as constituents, and then they get some skin in the game. And so for that reason, now I love fundraising because it really is about coming up with ecological and holistic solutions. One of the things that we have done, as I mentioned, Google is a really big partner to us, and they're not just a financial partner to us. Their teams, in terms of their Google Life Sciences, their marketing teams, and other members of the teams at Google have really been instrumental in informing the work that we do at the Center for Youth Wellness. In addition, I would say some of the work that we have done is really thinking about, okay, so this is a gigantic problem and it's a public health problem. And we recognize that in order to solve a public health problem, we need to have a broad and diverse group of stakeholders in creating solutions. And so one of the things that we did in California coming out of our Adverse Childhood Experiences Summit that CYW hosted last year was engage a broad group of stakeholders, not only with the business community, but also with public-private partners within healthcare, within juvenile justice, within child welfare, within education, and also in early childhood. Because we recognize that none of us is going to solve this issue by ourselves. BT dubs, if you talk to anyone in any of those fields, if you talk to anyone in education or anyone in juvenile justice or early childhood or child welfare, every single one of them will tell you that their number one pain point, okay, the young folks for which they have the most difficulty reaching and the least success are the children with the highest doses of adversity. And we have the opportunity to be on the front lines to really create an ecological model. So how, where does education fit in? Where does healthcare fit in? And in primary care, we see little ones when they're itty bitty, and we have the opportunity to be the first line of defense in screening and doing high quality interventions. The other thing that I would say about plugging into community resources, we reached out to the community and we do regular trainings. We've done trainings for San Francisco Unified School District. We've done trainings, obviously, for other providers. And then we've also even developed a training and a curriculum for the San Francisco Police Department about toxic stress and what that means. What that means when there's decreased functioning of the prefrontal cortex and overaction of the amygdala, and how police officers really need to recognize their own history and when that comes in, and then how they interact with young folks for the purposes of public safety. So in addition, we do have a pretty broad set of resources in terms of having multidisciplinary care, but we also have partnerships with external providers, and I do believe that the quality of that external referral is really important. We need to know who are the folks who are actually going to follow up, who are going to treat our families with respect, who's really going to understand what the biology of toxic stress is, and treat our patients as such. The last thing that I want to add, I'm just going to throw this out there, and I know that there's limited time, are just two pieces. Number one, in terms of resilience, I think a lot of us use the term resilience, but we really need to have a science-based framework. We heard Dr. Forkey talk about the decreased humoral immunity and the increased inflammation that's associated with toxic stress. And I want to make sure, particularly for this audience, that we highlight that absence of behavioral symptoms does not equal resilience. After I did my talk that was released on TED.com, the number of emails that I got from folks that said, "Oh my goodness, I was raised in a family with extremely high adversity, and we always wondered why my one brother succumbed and the rest of us were resilient. And then I saw your TED Talk, and I realized none of us were resilient. There's 4 siblings in my family, and my one brother had mental illness and ended up incarcerated, but the other one has diabetes, the other one has terrible COPD, and I'm morbidly obese," right? For some reason, if we see behavioral symptoms, we say, oh, and we connect it to the history of adversity, but when we see cancer, when we see ischemic heart disease, when we see asthma, when we see diabetes, we do not connect it. And this is the critical work that we in this room need to be doing.
Who's that?
I'm not that fired up talking about community resources. So I kind of have 2 ways of thinking through this. Obviously when we screen parents for their adverse childhood experiences and their resilience, we need a different set of resources at our disposal than if you're screening children, right? That's one side of it, is how we found those particular resources. The other side is how I personally started building relationships throughout the community and understanding what was available. So we have a care coordinator in our office, and she does a lot of homework for us when we are looking for specific resources. And she started, when we started our screening, she started looking specifically for parenting classes, support groups, relief nurseries, home visitation, any apps and website information that was available, and then mental health providers. And that was the biggest piece of her work. And most of that she found the parenting classes and support groups through an agency that's called Child Care Resource and Referral, which is in every county in our state. I don't know other states how that's modeled, but they are the resource bank for those types of resources. And so that was particularly helpful. And then the relief nursery person I happened to have met previously. And then home visitation, again, county-based program. So that was something that was easy to find. That said, once we started doing this screening for parental adverse childhood experiences, and this will happen to any of you who approach ACEs or resilience in any way, you'll start putting your trauma lens on in other places and start realizing that you need other resources. Just a story. I had a kid in last week, a 13-year-old, who is a cutter, which is one of those, I can never get my brain around that exactly, why that happens or how to deal with that. And when I started listening to his story, he also had a history of pretty severe anorexia over the year prior, had lost something like 40 pounds. He had some anxiety symptoms. He identified himself as gay at the age of 13. But getting into the story, his mom was bipolar, substance abuser, had been in and out of jail 3 times in the 18 months previously, and he was living in a 63-year-old aunt's house. Okay, so obviously the medical model, does he need a psychiatrist? Yeah. Does he need medications? Maybe. But what he also needs, if you start thinking about resilience, is connection. He needs a place where he feels competent and confident. So I started thinking about mentorship programs like Big Brother, Big Sister. I started thinking about the Boys and Girls Clubs where he could participate with other peers that might support him. I started thinking about gay and lesbian alliances within his school and within the community. So again, once you start taking this trauma approach, then you will start finding other needs that you have. I think the third community resource, I guess, that I would put out there is that it's not enough for me as a provider to be thinking about trauma. I need my entire office to think about it, and that requires some degree of training in trauma-informed care. The Oregon Pediatric Society, which is our AAP chapter, has launched a trauma-informed care training, which I think is extraordinarily helpful for the entire staff to think through. Certainly our advice nurses have frequently come to to me grousing about some difficult mom, and when I tell them the backstory about the domestic violence or about the recent divorce or whatever, they say to me, oh God, I wouldn't have responded the way I did. And I said, well, let's get you to the point where you never feel like you need to respond the way you did, and just take that perspective that probably the people who are difficult are having something that they're going through. And that really requires a clinic-wide approach. So in terms of community resources, figure out somebody in your area who does trauma-informed care training. Now, beyond that, in terms of how I personally started developing relationships, I went first to our public health department, Defending Childhood Initiative. Erin Fairchild is the person that I met there probably 4 years ago or so, and it was when I first started doing the Project Advisory Committee. And when I told her what I was thinking about doing within the practice with screening parents for their adverse childhood experiences, she very politely told me that she didn't agree with me doing that, given that I'm not a mental health provider, and what could I possibly do. But that said, once we talked through the process and what sort of supports we could offer, she has slowly come over to my side, I guess, although it is something that I think you need to do with some thought and consideration. But she introduced me to a number of other resources that I probably wouldn't have ever thought of before, and through that, I have been participating in Washington County, which is one of our Portland metro area counties, has been doing an ACE collaborative for the last 9 months, where they're trying to get to the idea of a sanctuary model of care, which some communities have very successfully done across the country. And when you go to those meetings and you meet the police chief and you meet the relief nursery person in person, when you meet Youth Contact, which is this great organization that does counseling and peer mentoring, that's when you really start making those connections. So once you find some avenue in, probably through public health, then you'll start meeting all sorts of people. The other thing that I guess just, two other sort of quick stories, and then I'll shut up. One is that I bought a ticket to a fundraiser for CASA a few months ago, which is a court advocacy program. So they are the people who go into the courts for the kids in foster care and have their backs. And the fundraiser was at a winery. I won't say how much I had before I talked to her, but I very politely went up to her and said, hi, I'm trying to put you out of business. And she said, I beg your pardon? I said, well, it'd be great if we could prevent all of this, right? And so that sort of started another set of conversations about, people who I might need to know and people that I need to connect with. I also recently had it turned out to be a pleasure. I'm not much for public speaking, and I'm not much for being interviewed, but I had a reporter from Kaiser Health News who followed me around for 2 days and took a lot of pictures, which generally a bad idea with me, and wrote an article that ended up in our Oregonian of me basically telling our story of what we were doing. And then I had people starting to contact me. So I now know the yoga studio across town that does trauma-integrated yoga classes. I guess the last lesson would be tell your story, and the people will come to you.
Thank you. Larry, did you want to speak? Larry Wissow.
So just a couple of things to add. I mean, one is that, and I think this follows on one of Dr. Dowd's slides, was the idea that so many of these collaborative networks are very personal when we're dealing with this kind of an issue, and the need to trust the people that you're working with, and the need for them to trust you, and then for you to be able to create this safety or secure net in which you can collaboratively work with families is really important. So an awful lot of, I think, as RJ was saying, is really the time that you can take to go out and actually meet people and to form relationships with them, or to cultivate additional relationships with people that you already work with. One of the things that we've done in Maryland, and I'm looking at Ken Tellerman here, who will try to keep me honest, is to try to think about how we can create local networks between mental health providers and primary care providers, and certainly people in other community resources. And at least one of the ways we started to do that was first to go to the parent organizations, to NAMI, to the Advocates for Children and Youth, the different groups that actually work with, that are largely parent-run organizations and that work with kids who have significant problems, and ask them to almost sort of walk through their kids' lives, walk through their kids' cases. Who do they need to connect, and who have they successfully connected, and to make that our starting list of who we would want to try to sort of knit together. And then through the working with the Maryland chapter of the Academy, we've tried to do training events that have brought people together from across disciplines, so trying to have mental health providers and primary care providers come to the same event, have mixers where people can get to know each other so that they get to know each other's areas of expertise, and realize who within the same community is actually still working on the same sort of thing. One of the other things that we've tried to do in the state, and the state's been good about financing it, has been also trying to place social work interns in primary care offices for training experiences, and we're hoping soon to expand that to LCPCs and with any luck, maybe even to psychology students. And this starts to sort of build really from the ground up what the kind of collaborative care networks might be within communities. Obviously, there was a wonderful study done by Greg Fritz, who was now the incoming president of ACAP a million years ago, which suggested that people really imprint on people that they encounter in practice. So I think one of the other really big challenges is trying to help our pediatric residents understand right from the get-go how to work with people in schools, how to work with people in other disciplines, so that once they get out of training, they'll just sort of naturally do it as opposed to have to learn how to do it.
I'm going to have Denise Stouts share some comments as well, but please feel free to start coming to the microphones if you want to ask some questions. I don't see anybody standing up. Otherwise, I'll just start asking some of my own.
Yeah.
But I'm going to have Denise share a couple of thoughts while you're coming to the mics.
Great. So come on right up. Just to add to what everybody else said, it is all about relationships. To quote, it's what Andy always says. And community connections are just that. They're personal relationships. And I think the key to a good personal relationship is if you're going to have somebody go out, send a socially, emotionally, intelligent person to go out. And I don't want to insult anybody, but my salesperson brothers are so awesome at this, but it's more about relationship than it is about content knowledge. And I think we as physicians hold so near and dear to factual empiric data that sometimes we're a little rigid when it comes to interaction. I'm not trying to insult anybody or anything, but there are people that have been doing this work at CASA and with social work and psychologists for years and years and years. And I think what we can do is we come to them and say, hey, look at the biomedical evidence. Telomere length is changing. Cytochrome P450. Look at the cortisol levels. The work that you're doing is influencing this. Did you know about this? And what that does is a couple things. One, it boosts them. It makes them feel like they're worthy. It makes them feel like they may be making a difference. And then the second thing it does is it attaches you to them. It's attachment theory. And that's what we got to do. I mean, this is a way we integrate systems, and I think that's the greatest hope. So that's the only thing I would add.
Thank you very much. Okay. So let's start at the center mic.
It's on? Yeah. Hi, I'm Dana Silver. I'm from Baltimore, Maryland. Hi, Larry. So my question is, I guess any of you can answer this, which is my patients are majority Medicaid. I send them off to counseling, to therapy. Are there ways to ask the therapist what they know about how to address these issues, or are therapists all receiving this information when they're getting their training? I assume not.
I'll just add something, because I had the same experience initially when I started screening for ACEs, and at CYW we ended up moving to we have something called multidisciplinary rounds, where we actually have our multidisciplinary team, our pediatricians, our case managers, our nurses, and our therapists and our psychiatrists. talk about our most challenging cases and come up with a multidisciplinary treatment model. But most often, and prior to that, it didn't happen, right? And these things happened in, oftentimes the care was happening really in isolation. And sadly, I'll tell you, a lot of the time I just had to get a release of information and pick up the phone.
Well, and I do that, and I think that, the caveat to that is that we never hear back from them. Even when I get a release of information, I have to call and call and call, and they don't call back.
Mm-hmm. So that really is typically the case, and that really happens a lot for us. Sometimes when I'm dealing with an outside mental health provider, I have the same experience. The one thing I do want to mention about the relationship that we have with our mental health colleagues is that I believe strongly that it needs to be a bi-directional relationship. I know that our mental health colleagues, I give our mental health colleagues a tremendous amount of credit for recognizing the risks that adversity and trauma play for a very long time. But I will tell you, I have had countless therapists and psychiatrists primarily, send me a note saying, this child is on X, Y, and Z antipsychotic medication. Could you please do a liver panel on them? Could you please check their lipids? Da-da-da-da. Never have I had a therapist or a psychiatrist send me a note that says, this child has an ACE score of 4 or 7. Can you please do spirometry? Can you please check their risk of asthma? Can you please check their risk of whatever? Or, for example, internally, one of the things that we're working on in our team is, for example, hey, Nadine, you did the screening and we thought that ACE score was a 4, but I've been doing therapy with this family for a year. Really, it's a 7. So actually, instead of double the risk of ischemic heart disease, this patient has 3.5 times the risk of ischemic heart disease, right? That is, I think, the science of toxic stress is where we need the field to go so that we can do a much better job of preventing morbidity and mortality.
I just want to follow up on what Nadine said, because we had a parallel that comes from Ethiopia. We were working on a project that involved trying to get HIV providers and the mental health providers to sort of work together. And the genius move that I didn't think about was not just teaching the HIV providers about mental health, which was teaching the mental health providers to do provider-initiated counseling and testing for HIV, so that they then really created this interdependent, network that Nadine was talking about. So I think we need to go, do workshops on asthma at the ACAP meeting.
I would just say one thing practically is that in any community, if you come across a medical issue and you don't know exactly which specialist should handle, like our orthopedics department sort of has so diversified that some guy only handles like the left finger on the, on the right hand. So, I have to call orthopedics and then I have to get to this guy and get to this guy. But now, forever after, I know that guy is left pinkies only and I'm going to keep his name. So I would suggest that for mental health, that's the way I first took it too, is that I basically said to like our developmental and behavioral pediatric people, who would you use? And then I went to them and I said, do you do trauma therapy? And then I said, can I come talk to you? And then I had a person I could always talk to. And then that person, and that's all I referred to for the first 2 years. And then she said, oh dear God, stop. And
Okay.
So I would suggest kind of just taking it the same way you would handle a medical problem and do it for mental health.
Okay, with that, I'm going to move to the right-hand microphone because we have people waiting patiently.
I just want to add one quick
No,
thing
you
if I
don't.
could.
You don't.
Super quick.
Super quick.
Use Google. I know that's crude, but I actually Googled TFCBT in Portland, Oregon, and got a list. And then when I looked at the list, I was like, oh, well, I didn't know they did that. I didn't know they did that. Psychology Today actually publishes that online, so use Google.
And similarly, in Minnesota, we have a list of AMBIT-certified trauma-focused therapists, which is very helpful. So you may have that in your state, but that going to the provider and checking in with them is helpful as well. So right-hand microphone.
Hello, hi. I'm Hayes Bakken, UCSF faculty at San Francisco General. So as we're starting to do this work, one of the things that we've noticed, and you guys have spoken about it a little bit, is the importance as providers, but then also as staff, even frontline staff, to take care of ourselves in doing this work. If you could speak a little bit more, I know we talked about mindfulness, and we've had some traction in that with our MD providers. We're working on the residents as well. But even also how this is addressed, nursing staff, frontline staff, the people sitting at the front desk. We're realizing there's also just a lot of institutional trauma that we're facing, and if you could speak to how that's being addressed.
One of the things we're really lucky for in San Francisco is that, Ken Epstein, who heads the Department of Public Health doing the mental health initiative, is working on a training for trauma-informed systems and how systems can kind of concretize in ways that also are dysfunctional as well. I would say it's critically important. What you talked about, we do regular trainings both for our own staff at CYW and for the staff at the Bayview Health Center on vicarious trauma, on ACEs and toxic stress. One of the best things for dealing with that issue is that when our team members understand the neurobiology and the physiology of toxic stress, they have a lot more empathy when someone is up in their face. And they also understand if you want to do an HPA axis provocation challenge, walk into a room with a kid who has an ACEs score of 7 and try to immunize them, right? I've been bitten, I've been vomited on, I've been kicked, I've been punched in the stomach, right? But when you understand that this kid isn't trying to assault you, right, but they're having a fight or flight response, then you also understand, okay, I need to wait for this kid's adrenaline levels to come down. I need to teach them methods of self-care. And I also need to teach the parent what's going on so that the response from the parent isn't, hold him down. And that's one thing that our team does really well. We keep bubbles, those little bubbles, kids blow bubbles, in every exam room. It's one of my most important clinical tools, because when kids are starting to freak out, and I'm trying to get them to engage their vagus nerve and engage the parasympathetic response, we sit there and just have them blow bubbles when they get stressed out. So I think you're absolutely right. It's critical. And leadership, clinic leadership and organizational leadership needs to make it a priority. I would encourage leadership to make it a priority because you will save tremendous amount of costs in recruiting and retention if you train staff on the physiology of what they're dealing with and how they can do self-care.
I just want to echo the idea that that getting this idea of sort of cross-training of maybe setting up a leadership team that actually includes folks from the front desk, from nursing, from administration, from the medical side or whatever, and saying together we're going to sponsor this thing together, and we're going to come together as equals to talk about it and to talk about some of these institutional things and really in some of the work that we've been lucky enough to be involved in, what we really find out is that the people who are able to change the culture are often the people who, nominally have the least power to do it, partly because they're the people who have the most skin in it often. So really, your savior is probably sitting at the front desk.
Thank you. And back to center, Mike.
My name is Dan Levy, and I practice pediatrics in a suburb of Baltimore, which blew up this summer, both a general and behavioral pediatrician, and I'm the one who was guilty of asking about the business partnerships. And this is what bothers me about your response, and I hope that you will respond to what bothers me. What bothered me is that we're relying on businesses we're asking them for money. And I gave a grand rounds about a month ago at one of our teaching hospitals in Baltimore, speaking about the fact that what we really need to do is form business partnerships. I'm going to one of the local corporations that is a competitor of Nike, and I'm saying, look, help us form a business model for a transformational practice that's going to deal with the things we're talking about here. This is just consuming me. And if we don't have some sort of business model that's going to look at this at the same time convince businesses that this is the future of the workforce, we're not going to get anywhere. So maybe you can talk a little bit about what you're doing in Oregon, in the Bay Area, in the flyover zone in the United States. I'm really interested in what you would have to say.
I'll just really quickly say thank you for pushing back on me on that. As was mentioned in my introduction, I'm also an advisor to Secretary Clinton in the Too Small to Fail initiative. And through Too Small to Fail, we have engaged the business community and how we create systems to support parents and caregivers in ensuring that children have the best and healthiest early start, and beginning to address some of this business model conversation that you're talking about. My response was more on a personal level in terms of how I've been engaging with that, because that is my own personal role has been much more on the national advisory role, and the team at Too Small to Fail is working very hard to get businesses to make commitments, and that's one thing that happens every year at the Clinton Global Initiative, is that businesses make commitments about how they're going to take this information and actually implement it in the real world. I think that on on the work that we're doing on the ground in San Francisco, that hasn't happened as much, maybe because I'm more busy seeing patients and trying to raise money. I don't know. But it is happening on a national level.
I'll just give one little itty-bitty example of this. It's kind of on an individual thing, and it's a program in Kansas City that we work with. And what it is, it's called 100 Jobs for 100 Women. I know it's only 100 jobs, but it's a really important thing. It's been going on for about a year and a half. And the call went out from Sister Berta, our Mother Teresa over there, that employers needed to step up and be able to employ women. The only way they were going to get out of poverty is going to be able to have a decent job and provide for their family. And I say women because the majority of women-headed households. And so what this program is, and we rely on philanthropic dollars to make it work, at least to prove the concept, is that it's mentored employment. They're small family-owned businesses, not big corporations, but ones that believe in this issue. And we have a lot of women in recovery, so there are employers in recovery who really get it and want to help, and they do mentored employment. So the motto is no secrets. If you're a felon, you're a straight-up felon, you're going to talk to us about it. If we're going to call you out on things, we're going to give you guidance on how to not lose your temper, showing up, for work, all of that kind of stuff that deals with emotional self-regulation. This is the biggest problem, I think. And so far, 15 women have gone through it. They're all successful. Many have gone on to other jobs. And so I think we need to scale up things like that, but it does work. But again, we need philanthropic dollars. They've got to be paid a livable wage. But it's a small and hopeful example.
Thank you.
Thank you very much. We have just over 2 minutes, so I think we can take one more question from the right-hand mic.
Okay. So we're contemplating how to get this going in our university-based practice. I have 2 practical questions. One is, how do you enlist wellness coordinators and stuff that look like your population or come from the population you're serving? And second of all, how, once you get an ACEs score of 4 or whatever and you send them to your wellness coordinator, how do you get the patients to stay for that hour and a half visit? I mean, that's getting to be a really long period of time. And what do you do with the children while the parent is discussing these difficult issues?
Oh, yeah, I can. So at the Center for Youth Wellness, we do a warm handoff. So we have our wellness coordinators and wellness nurses who are embedded in clinic with us. So when we have 2 referral systems. One is if we have someone who's available right at that minute and they kind of sit at a desk in clinic, then I will just grab them and do a warm handoff. And at that moment, when I have a patient who has a high ACE score, I will say to the patient, I'm concerned that what your child has experienced increases their risk for health and developmental problems. And so I want to connect you with someone who can really help with that. And so I want to introduce you to Nurse Janet or Nurse Anita, and I'll walk them in and say, you remember those services I was talking about? Nurse Anita can connect you to those services, and I'll do a warm handoff. And in that moment, our team member will establish a relationship, and that way, that just increases our chances that when we do that follow-up call to get that family to come in for follow-up, that they know who's calling them, they've established a relationship and rapport with them, and they're more likely to come in. That being said, not every time can we do the warm handoff, and lots of centers, they don't have the warm handoff. And so our other method of referral is to say, okay, I'm going to refer you to someone, and usually I like to have a name, Mary or Bob or Sally. Sally's going to call you next Tuesday, right? So I'd like to be as specific as possible so that when the family gets the call, they know what to expect. And so that's our other model of doing that, and then we have them come in for an intake, and so that there's a specific appointment for that. You asked about how to engage families in this work, and I forgot to mention that we have a community advisory committee that's made up of community members, pastors, teachers, folks who work in the community, as well as parents and grandparents of our patients, and they advise all of our work that we do. They advise the development of our screening tool. We also have youth from a local high school, Leadership High School, that also advise the work that we do. So we try to do a lot of engagement in that way. And then we also have a community research board that we have similarly to advise and oversee our community-based participatory research. But there's one kind of final point that I wanted to add to this, which is that I think that in communities like the one that I serve, it's impossible not to see the impact of ACEs and toxic stress. It's impossible. Because our kids are failing at school, they're so ill, they have the worst health disparities. But interestingly, as I mentioned, I was just at Google Zeitgeist, and a woman came to me and she said, Dr. Burke Harris, I heard your talk. My kids are suffering from toxic stress. I got married too young. I made a mistake. I had some drama in my household. And that situation is sorted now, but since I've been trying to get help, it's been impossible. It's been just really hard to find because I go to my doctor and they don't know what I'm talking about. And this woman came to me and she was really desperate to connect to resources, and she finally was able to connect to resources, but she said, how do we have this conversation among my peers? And I said, oh, what is it you do? She's the CEO of a company that does $1 billion a year of ad sales with Google. It happens in every community. She lives on the Upper East Side of New York, and she said the hardest thing in the world is to have that conversation among her peer group. And so I just want to encourage all of us, regardless of what the demographic of our practice looks like, to think about how we can engage our parents and our caregivers in this conversation, whether they're in the fancy part of town or whether they're in the communities where it's most obvious.
Thank you very much. I really appreciate the kind words and the wise words that you've passed on to the audience today. And I'd like to thank our entire Community Resources panel for staying here today and answering questions. I really appreciate it. And I want to move on to our final speaker for the day, which is Robert Block. So Robert Block, first we'll take the panel.